Good afternoon. I'd like to thank the committee for having me here today and speaking to all of you on physiotherapy. I think I'm the only physiotherapist here. I may be wrong, but so I'm the person that people tend to see after treatment. So we're going to change gears a little bit. Just to start, I work as a consultant for a medical group in Montreal. And I'd like to just go over some of our learning objectives for today. So first, I'd like to describe the role of a physio in the gynecology oncology patient. I'd like to be able to go ahead and identify some of the dysfunctions that we'll treat, and then we'll be able to identify appropriateness for referrals towards a physiotherapist, because sometimes that's a little bit of a gray zone. A little bit about me. I'm a registered physiotherapist practicing in Montreal. I work in the private sector, so I treat a variety of pelvic floor dysfunctions mainly, but as well as orthopedic conditions, so a little bit of everything. The pictures that you see in front of you are my last adventure, where I was in the fall in Senegal teaching an outreach program towards gynecologists and midwives about pelvic floor re-education. It was greatly received, very rewarding for myself. But back home, whenever people hear about a physiotherapist, they get excited because they think I do massages. And I promise that's not all I do, not just massaging pelvic muscles and vaginal tissues. However, when I tell them gynecology, they look at me with a blank stare. So we're going to go through a lot of content. We deal a lot with the musculoskeletal system, and I'll be able to break that down a little bit. So some of the dysfunctions that we'll treat mainly are urinary, bowels, and sexual functions. So that we're going to go through those more in depth. So in the oncology patient, after radiation chemotherapy, I often find that there's big stenosis in terms of the vaginal canal, a lot of narrowing, agglutination where the tissues become very tight, and even shortening of the canal. That has a direct impact on the pelvic floor musculature. It impacts their functioning tremendously. They're not able to have the same amount of tone. They can't exert the same amount of force and power and endurance. So a lot of disruption within the urinary, bowels, and sexual functions. In cancer survivors, what we've noticed in studies is that they report that they often have an improved quality of life without having any adverse medical effects. So that's great for me. So the first question I invite you to all to answer on your tablets or mobile devices. Okay. All right. 100%. Fantastic. So 80% is the improvement in following physiotherapy. Perfect. So that's really, really great outcomes for our line of work. So just to go back to the foundation about what the pelvic floor does and what it is, I try to demystify that a lot for my clients. They hear about it, but they have actually no idea where it is, what it is. So in terms of supports, that's the biggest action. The deepest layer of your muscles are your pelvic organ support. Then they aid for the voiding and defecation of your organs. They improve sexual arousal. But more importantly, they also have a big role in maintaining abdominal pressure. So it has to do a lot with our activities, how we move, and a lot with our breathing patterns. Now, whenever I clinically talk about the pelvic floor, when I tell people that all they have are muscles and soft tissue, connective tissue, ligaments down there that are holding up their organs, they're very motivated to do their Kegels after they find that out. So it's important to sort of break that down for patients, have them see what we're working with. And the different layers of the muscles have different functions, but I'm not going to spend too much time on that for today. Now, the biggest dysfunction that we tend to treat is urinary dysfunctions. 1 in 4 women will deal with incontinence at one point in their life, and range from urgent incontinence, stress, or maybe a mix of the two. Now, incontinence happens when pressure wins. So when abdominal pressure trumps urethral pressure, there's a leak that could happen. So the pelvic floor intuitively should be able to co-contract right before that increase in abdominal pressure. And as we see on the video on the left-hand side of the screen, when the pelvic floor is poorly coordinated, you can see an increase in pressure inferiorly down towards the feet, and then you can have a higher incidence of having a leak and, again, prolapse. Now, if we move on to the picture on the right, whenever we coordinate the pelvic floor contraction, a little term we call the knack, a cough is well supported and contained within the abdomen, and less translation towards the feet, less movement of the organs down towards the inferior aspect. I'm ready to move on. I can't click. Okay. So for a latest study in 2014, they polled gynecological cancer survivors on their improvements in urinary dysfunction. Those who reported moderate to severe urinary incontinence had the most significant improvement in their symptoms, and all they had to do was a 12-week training program. So it was a Kegel program of just doing 5-second contractions 10 times, repeated over 3 times in a day. And after 12 weeks, they reported a significant increase. Those are really good stats for me to tell to my patients, and it encourages them to be consistent with their exercises, which is what they need. And so we're a little bit of a coach whenever we're doing these exercises with them, and we push them to keep going. Now, the second dysfunction that we'll see are in the fecals, so functioning. There's increased prevalence whenever we have changes at the sphincter, whenever the anal rectal or colorectal area has been either operated on or through radiation, or if there's even been damage to the pudendal nerve, the nerve that innervates the pelvic floor. But of course, through constipation. And constipation is not only limited medically to radiation or chemotherapy, but people can have been sufferers for a long time. And this has a strong correlation with pelvic organ prolapse, which is the third dysfunction. 20 to 53% of prolapse can be occurred from chronic constipation. So when we educate a lot on maintaining proper bowel functioning, we can improve their prolapse issues as well. So prolapse can happen in any of the pelvic organs, either being the bladder, the rectum, the uterus, and if the uterus is removed, of course, there can also be a prolapse just due to the reorganization of the anatomy. Sexual dysfunction is by far the thing that I stress the most whenever I work with my clients. I make it a good point to take a good subjective history because it's a lot more common than we think. A lot of the times what we've noticed is that cancer patients don't tend to report sexual discomfort. What they tend to say is that I'm happy that I've survived the cancer and just help me stop leaking my pants. But then when we dive into the sexual component, we see that it's quite high. And those who have suffered from radiation therapy can have rates up to 55% of dyspareunia. And it's more common in endometrial cancer patients versus other types of gynecological cancers. In a study, they've noticed that 74% of cancer survivors wish that their doctors would have brought it up, and more than half of them said that the doctors didn't. So it's a good thing to be aware of these things, and although not many people may be talking about them, I think it's important that we open up the room to talk about it and to make patients feel comfortable and encourage that discussion. Now, for the bread and butter of a physiotherapist, it's the musculoskeletal system. So anything from joints, ligaments, tendons, and muscles, and they're involved heavily in pelvic floor dysfunctions. So anything from interstitial cystitis, vaginismus, vulvodynia, you name it, the MSK system can have a role in that. So the next few slides, we're going to go through some of the MSK systems that could contribute to some of these pathologies. The first being the most important. Clinically, I describe the myofascial system as the interface between skin and muscles. So the fascia that connects all our body, it's a connective sheath from top to bottom. And oftentimes when muscles are spastic and tight, the connective tissue that's overlaying that becomes very adherent and bound. So this can be a source of 70% of pelvic pain whenever the myofascial system is implicated. So trigger points, so what we call knots, quote unquote, can happen in these hypertonic muscles. And whenever we palpate these trigger points internally or externally, they often reprovoke symptoms. And as we see on the image here on the right, the obturator internus is a very vulnerable site for myofascial trigger points, and especially for nerve entrapment as the pudendal nerve moves through it. So that's an area that we often treat. Now, for the connective tissue, which is really that layer that exists over the muscles, that, like as I said, can become very adherent to the muscle. And when it becomes kind of adherent, it's somewhat sticky almost. You can't glide the tissue separately on one another whenever we're doing mobilizations on the tissue. And it's very adherent whenever we're doing vaginal exams. And that oftentimes causes a lot of sensitivity to the touch. So our patients will sort of report irritation from different clothing, sensitivities to different textures, even from compressions from a chair, for example. So that's important to take a look at as well. Now, viscerally as well, we can see inflammation within our organs, such as bladder or within the abdomen. It can also cause a recurring vasoconstriction of the connective tissue surrounding those organs. This will also cause a secondary muscle spasm that happens around. So the inflammation causes the connective tissue to be bound, and then the connective tissue causes the muscle spasm. It's kind of this vicious cycle. So I invite you to answer the second question coming up. Should repeated negative vaginal or urinary cultures be considered referral for physiotherapy? Good, and I think we have most of our answers in. All right, it's kind of moving around. And the answer is yes. So the reason for that being is through a spinal cord reflex, whenever we have negative cultures that are always coming back repeatedly, an MSK source is highly probable. So through spinal cord reflexes, what happens is that the inflammation from the bladder, for example, if it's a urinary infection, will cause the muscles around the urethra to spasm. And then that muscle constriction will cause, again, a propagation of the symptoms. So difficulty initiating urination, for example, burning, itchiness, etc. Now, when we look at nerves, that's another source of pain, for example. So we assess nerves through their mobility. Unless somebody is reporting to me discomfort in a very specific dermatomal area, then I will go ahead and maybe investigate the mobility of these nerves more in depth. However, whenever a nerve crosses one or more joints, then it's easily assessed through some joint stretches. So we're going to go ahead and talk about that in the management. Now, for a little bit more of a global approach, trigger points, as we talked about in the myofascial slide earlier, they can also exist in other external muscles. So maybe not muscles related to the actual pelvic floor, but in and around the surrounding areas. So trigger points within the quadratus lumborum, for example, in the lumbopelvic complex, within the rectus abdomini, and even trigger points specifically to the levator ani, will all concentrate pain in and around the pelvic area or even refer pain there. So whenever we do an internal assessment, if we're not reproducing any symptoms, I'm going to go ahead and look in and around the area to see if there's any other factors that we're missing. Now, when I come to the internal evaluation, it's really important for me to measure the tone of the muscle. That's the resting state of the muscle, and that gives me a lot of information. The best way for me to tell the tone is to compare it to your thenar eminence. If we all do it together, and you grab your middle digit and your thumb together and palpate the inside of the tissues, and then you keep going towards your ring finger and your pinky finger, you might notice that the tone underneath the thumb starts to increase. And oftentimes, the really tight spastic pelvic floor feels like a thumb to pinky. So that's what we call a hypertonic muscle. And oftentimes a hypertonic muscle doesn't mean that it's a strong muscle. It's actually the reverse. It's a weak muscle. The length tension curve has now changed. The muscle can no longer contract anymore because it's reached its plateau, and it can no longer relax. It just stays where it is. So when we down-regulate the muscle and teach it to eccentrically lengthen, then we can actually get a proper contraction. So that's how it affects a little bit about the functioning of the muscle. So oftentimes we get a contraction, the relaxation is inexistent, either it's extremely slow or it's stuttered or incomplete. So these are all things that we assess. And then to finish it off, if I have the time with my patients, we'll look at their posture. Oftentimes I can get a good idea about this as they're standing in front of me as I take them to my office, and then we can correct. As in the second picture over here of the lady who is in a bit more of a sway back position, there's a lot of muscular imbalances, a lot of weakening of the anterior abdominal wall, and a lot of shortening and tightening of the paraspinals, which we know a trigger point in the quadratus lumborum can be a source of pelvic pain. So again, it's good to tie it in all together so that we can maximize the benefits. Now for the management, as physios, our bread and butter is talking. We love to talk and educate our patients. We can work with them up to 60 minutes, so we have the leeway to do this. So I modify any activity that can over-increase abdominal pressure if they've been suffering from urinary leakage. If they're talking about urgency or frequency symptoms in terms of their bladder, we remove any irritants such as caffeine, nicotine, alcohol, and we play around with that. And then for anybody who's reporting discomfort at the vulvar area or any poor tissue integrity symptoms, we'll talk about vulvar hygiene, changing either types of garments that they're wearing, switching to cotton, maybe removing soaps, and using a good moisturizer to lubricate the area. Now, when we go towards the bladder and re-educating that, anytime that we have urinary incontinence, urgency, or frequency, I get my patients to do a diary. They log 3 days out of their week. Their habits at work and their habits at home are usually very different. Somebody who's sitting at their desk next to the bathroom might urinate once an hour, but at home she's so busy she might not be able to get to the bathroom on time because she's taking care of her kids. So it's important for me to give her the strategies and the tools when she actually needs them. And then we modify their behaviors, and in that. A lot of people don't even know how many times they should be going to the bathroom. So when I tell them it should be between 5 to 8 times and not once every hour, they tend to slow down their frequent visits to the bathroom, and that allows their bladder to stretch better, hold more liquid, and then they can get to their day onwards. Now, we know that constipation is a big correlation with prolapse, so we deal a lot with evacuation education. We talk about proper stool consistency. On the Bristol stool chart, I show these to my patients, and I get them to try to get to a grade 3 or a type 4. They do that through proper hydration, diet, etc. Now, positioning is another thing that's very important, gets them a lot more comfortable. People who bear down and strain a lot to evacuate their bowels in an unhealthy posture, as shown on one of the images here, they won't really get towards the exit properly. If we get them to use what we call a squatty potty, it actually works a lot better and they don't have to force as much. And then those who can't steer clear of bearing down, we talk about breathing techniques. Pursed lip breathings or breathing into a fist, like that, can avoid bearing down as if they're going through labor all over again. So now for the bread and butter, a physiotherapist, yes, we do massage. I do a lot of myofascial techniques. So we know that myofascial system is a big trigger towards pelvic pain. So I do a lot of manual release in terms of the trigger points. I try to find those really irritated spots, those really tight spots. So we work on that. I work a lot on scar therapy. So anybody who's had an abdominal incision, either through laparoscopic, even if they're small incisions, or through maybe a C-section scar, for example, oftentimes we find that the tissue is bound. You look at their abdomen and there's a nice big fold where the scar is. That tissue should theoretically be very mobile and loose. So we try to work on that. And now internally, as we were mentioning about a hypertonic spasmic pelvic floor, we don't do Kegels on those because it won't make any sense to strengthen a muscle that's already shortened and tight. So what we do is we relax the area, we eccentrically lengthen. We get the muscle from up here to learn how to live down here. So that's what we call a reverse Kegel. So some of these techniques I have shown here on the right. And now when we talk about the peripheral nerves, a nerve that's less mobile can create, again, referred pain along the nerve pathway. So we check about the integrity about that. Whenever we move our bodies, our nerves should move with us, and sometimes they don't. So we mobilize a nerve, and we call this flossing, because we cannot stretch a nerve the way we stretch a muscle. That would irritate the nerve. We cannot statically stretch a nerve. So we glide it in and out of its nerve sheath. And so as we see here, for somebody who has sciatica, for example, this is one of the common ones that we'll give. And we get them to move the joints that are the sciatic nerve moves through. The femoral cutaneous is another source for pelvic pain. We'll get them to do a floss like this. And then the pudendal nerve will be a variation on this pose, and we get them to move the hips in and out of flexion. Now for manual therapy, again, when we see that there might be some dysfunctions into the lumbar or pelvic area, we do a little bit of joint work, either through mobilizations, manipulations, etc. I'm certified in dry needling, so I find that very effective to release intramuscularly some trigger points into those external muscles, as we saw earlier. And then we want to restore proper movement patterns, strengthening the muscles that need to be strengthened, such as glute medius, piriformis, for example, and stretching out maybe some of your adductors that often get very tight. Now, for the patients that come to see me mainly for dyspareunia and for pain with intercourse, we absolutely do dilator therapy. I often give them the purple set of dilators here, which is a Laura Berman set. It's a progressive insertional tool that we introduce into the vagina slowly, and we do a series of stretches that are shown below. And within these directions, we find that we can eccentrically lengthen the muscles much better. We can get rid of those tight spots within the muscle, and it gets them to also relax and get used to a little bit reintroduction towards intercourse. Oftentimes there's a lot of fear and anxiety, so when patients get to do it themselves, autodilation, they're the ones in control and they feel a lot better with that. The image on the right, the Thera one, is the gray one. That's more for rectal manual release. Now, in terms of intercourse, lubricants go a long way. As we know, with radiation and chemotherapy, it changes the integrity of the tissues, often very dry. So I always recommend an oil-based if patients don't need to use latex. Coconut oil works great, but if they don't like it, then we recommend some of these other brands. And I tend to steer clear away from KY, Astroglide. All those have a lot of parabens and tend to irritate a tissue that's already maybe irritated. We talk about different positions in intercourse, and I usually get a lot of questions about that. But for somebody who's talking about deep dyspareunia, using pillows to tilt the pelvis in an anterior or posterior direction may reorganize some of the pelvic organs, making intercourse a little bit more comfortable. And we treat the person as a whole, and we find that yoga therapy is very beneficial. It not only works in terms of fascial stretching, but tends to down-regulate the nervous system that tends to be a little bit on high stimulus, I should say. We teach a lot about pain education. Lorimer Mosley is a famous physiotherapist in Australia, coming out with a lot of pain education, and we start to integrate that into a biopsychosocial approach in physiotherapy. So we're not only manual therapists, but we tend to be the listening ear a lot. So we talk about how pain is interpreted, how that increases their fear and anxiety. That has a feed-forward response on their muscle tension. They tend to be more spastic. So when we explain it in a whole, slowly and gradually over the weeks of sessions, it's not all on the first, they tend to digest that a lot better and feel more in control with the symptoms that they're dealing with. Some of the strengthening programs, now after we've down-regulated the pelvic muscles, we strengthen them, right? If they're dealing with urinary incontinence, if something is tight, I release it first, and then what we do is we strengthen properly with that full relaxation. And these are some of the examples of the strengthenings that we do. They're pretty hard. If ever you've tried any of these, it's not just contracting and holding. You have to do some of them quickly. Sometimes you have to coordinate it like an elevator going up to the 3rd floor and then going down to the 1st floor. So it's pretty tough. And then next, we can integrate the pelvic floor muscles with abdominals, for example. If I have a weightlifter in front of me, it's not just Kegels. I learned for them how to brace their abdominals, get them to use maybe their obliques and other supporting muscles that can help them return to activities fully. Now, lastly, for my prolapse patients, I do encourage the use of a pessary, especially if they have a high-grade prolapse, especially up to grade 3. However, they can't get away with just a pessary. Always do the pelvic floor training, because if you just correct the position of the organ, you're not correcting the deficit of the weakness in the muscles that are laying low. So that's important to be done in conjunction. We also talk about different postures and positions that can help alleviate pelvic congestion and maybe reposition the organs if they've been standing up all day and feel a lot of heaviness. Now, for my case study. So this is a lady that I saw last year. She came to me complaining of dyspareunia for over a year, progressively worsening. That was her main symptom. She also complained of urinary incontinence, increased frequency, constipation, lower abdominal pain, just everything in the whole sector. She had a hysterectomy as well as ovarian ectomy in 2006 and 2003. But her latest surgery was a gastric bypass, and in my opinion, that was the thing that sort of set her off the edge. She really wanted just to have pain-free intercourse, so that was my main focus. I knew right away we had to go towards dilator therapy at one point. Her obstetrical history didn't have much to note except for a high-grade tear and maybe some forceps that may have put a little bit of trauma onto the pelvic floor, but not as bad as the surgeries, I would say. When I subjectively ask her about her symptoms, I always organize my evaluation on urinary habits, bowel habits, and sexual habits. So we go in depth for each of those 3 categories. She was pretty frequent, going once every hour, twice at night. She was just spending most of her time in the bathroom during the day, so we wanted to work on some behavioral modification. She had a hard time initiating her urine stream. She had to push to evacuate her urines. Now, in terms of the bowels, she also needed to push, but they were sort of all over the map. She was going 3 times a day, maybe once every 15 days. That was due to her gastric bypass. So when I investigated a little bit further, she hadn't seen a dietitian. She didn't really know how to intake fluids properly or different fluids. She couldn't drink from straws, so it was limiting her on how to properly modify her bowels. Now, her biggest symptoms were the sexual functions. So she had pain at the introitus and deep within the vagina with any kind of penetration, 1 digit, 2 digits, speculums, and intercourse. Her pain lasted up to 2 days after intercourse, so it wasn't very fun for her to even do that. So she really steered clear from intercourse and sort of built a bit of an anxiety wall towards that. And so that's where the psychosocial comes in. She didn't report any heaviness, so I wasn't concerned about a prolapse. However, I still need to check in my evaluation. So on to the objective exam. When I looked at her globally, I knew I needed to go right away to the pelvic region because she had a lot of symptoms there. I assessed really briefly her posture and her breathing pattern. When she took a breath in, she took a nice inhalation and her stomach went in, not out. Now, that didn't allow for her diaphragm to downwardly move, so that she was pressing all of her muscles in and against her organs, causing a lot more tightness, probably propagating her bloating and her discomfort. When I looked at her incisions, they were extremely tight. Basically, one skin over the other, the incision right in between, couldn't even lift anything. So I knew we needed to work on some myofascial release at the abdominal wall to get her a bit more comfortable. When I looked at the vaginal exam, externally, didn't see much. It was unremarkable, really, other than maybe a little bit too pale in terms of a coloration, so I knew maybe things were a bit dry. Elasticity wasn't great, so I knew I needed to work on that a little bit. Her contraction was very poor. She had a lot of compensatory mechanisms using her buttocks to help with her Kegel, so I knew that she had a bit of weakness. And then when I assessed internally, I did see a small prolapse, but it wasn't my primary go-to. However, her strength was poor, as I suspected from the external exam, and she had a low-grade tone within the pelvic floor with incomplete relaxation. And when I assessed a little bit deeper within the vaginal canal at the anterior compartment, it reproduced her symptoms that she felt during intercourse. So I knew right away what I needed to work on with her. So initially, we focused a lot on breathing, evacuations, 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 proper positioning, proper breathing, proper diet. That really helped her out a lot. So that was her initial management. After that, we started to layer on some of the manual techniques. I would mix in a bit of scar mobilizations during the session, and then we would do a bit of internal work at the pelvic floor using the dilator and manually as well. At home, she took her dilator kit, and she was very diligent about doing her vaginal exercises. And within 8 weeks, she actually started doing her vaginal exercises with her partner, which actually helped her nervous system downregulate and be less anxious to the return of intercourse. So I tend to integrate that a lot in my practice, and it's very useful to invite the partner to come in if willing, and I show them how to do the exercises on the patient using the dilator. And then by 3 months, full pain-free intercourse with improved urinary incontinence. So that to me was a success. Unfortunately, I didn't have a patient that had radiation therapy, but considering all of her surgical interventions, I thought that was a very good case for today's talk. So with that being said, I conclude my presentation on physiotherapy, and I hope I've convinced you a little bit that we can be helpful in this population and that it could be great to refer your patients if ever they complain of these symptoms. That's it.
Thank you. Thank you. That was very informative. Are there any questions?
Sure.
How much does it cost to see you?
Yeah, good question. It's unfortunate that pelvic floor physiotherapy isn't streamlined here in Canada. It's a very different outcome out in Europe, where women, this is more postpartum, are sent automatically by the government 6 times for a session. Now, in terms of pain-related cases, it's not yet, but it does cost around 120 for the session. Depends on where you are within the city. I work in the core of downtown Montreal, so it's a competitive market. So for me, we charge at 110, so we're right in the middle. It is covered by insurance, so I always ask patients to provide me the referrals and whatnot, but it is a bit of a limiting factor, but they tend to walk away with so much knowledge and, more importantly, empowerment. They never knew anything about their pelvic floors beforehand, and they feel much more in control about their situation. So even if they can't see me many times, I give them a lot of information, a lot of tools, and the goal for me as a physiotherapist is to provide independence. I'm not there for them to come back to see me. I want them to do better and stay home. So.